Every year, hundreds of thousands of older Americans agree to elective surgeries, trusting that the recommendation in front of them reflects the best available evidence. Most of the time, that trust is well placed, but here is what most patients are never told before they sign that consent form. For several of the most commonly recommended procedures in adults over 65, the research tells a story that is meaningfully different from what happens in the average surgical consultation. And that gap between what the evidence shows and what gets communicated in a 15-minute appointment can change the rest of someone's life. I am Dr. Linda Thompson, and on this channel I bring you clear, evidence-based health guidance designed specifically for adults over 60. Today I want to walk you through 5 surgeries that are routinely recommended to older adults, where the published research raises serious questions about whether the risk-to-benefit calculation is being fully and honestly explained. This is not about distrusting your physician. The vast majority of physicians are doing their best with the time and information they have. This is about making sure you walk into that conversation with the right questions already written down. Many of the people I have worked with told me afterward that they wished they had known this before their procedure. Not to avoid surgery entirely, but to ask better questions, to slow down, to understand what the evidence actually said before they agreed. Stay with me through all 5. Because the action steps at the end of this video are specific enough to use at your very next surgical consultation. The first surgery is elective lumbar spinal fusion for chronic back pain. If you have been living with lower back pain for any length of time, there is a real chance a surgeon has already mentioned this procedure. The logic sounds reasonable on the surface. Find the unstable vertebrae, fuse them together, eliminate the movement that is causing pain. But here is what the research actually shows. A landmark study published in the New England Journal of Medicine followed patients with degenerative spinal conditions for 4 years and found that outcomes for spinal fusion were not significantly better than supervised physical therapy and targeted pain management. Not significantly better. For seniors specifically, the complications extend well beyond the surgery itself. Infections at the surgical site, hardware failure requiring a second operation, a condition called adjacent segment disease, where the vertebrae directly above or below the fusion begin to deteriorate under increased mechanical stress. And during a recovery that can stretch across many months, older adults face serious risks of blood clots, pneumonia, and muscle loss that is very difficult to reverse. Many people I have helped through this decision were never told that 12 weeks of targeted physical therapy delivered by a specialist produces outcomes that the research considers comparable to surgery for many spinal conditions. That is not a minor detail to leave out of a consultation. Dorothy was 73. She had been managing lower back pain for 2 years and was told surgery was her best option for getting her life back. She was active, independent, and deeply motivated to feel better. What she was not told was that she had not yet completed a structured course of physical therapy with a spine specialist. When she sought a second opinion at an academic medical center, that was the first recommendation. 8 weeks later, her pain had reduced significantly. She never had the surgery. Dorothy's story is not rare. Research suggests it is far more common than most surgical waiting rooms would lead you to believe. But here is what most people never realize about the second surgery on this list. And this one matters enormously for men over 70. The second surgery is radical prostatectomy for low-grade prostate cancer. The PROTECT trial, one of the largest randomized studies ever conducted on prostate cancer treatment, followed over 1,600 men for 15 years after diagnosis. The findings were striking. Men with low-risk prostate cancer who chose active surveillance had essentially the same survival rates as men who underwent surgery or radiation. The same survival rates. But the men who had surgery faced dramatically different quality of life outcomes. 30% experienced long-term urinary incontinence. More than 60% reported significant erectile dysfunction. These are not temporary inconveniences. For many men, they are permanent. For a man over 70 with a low Gleason score, this cancer is biologically slow-moving. Studies indicate you are statistically far more likely to die with this cancer than from it. That does not mean ignoring the diagnosis. It means monitoring it carefully with regular PSA tests and periodic biopsies. And it means not rushing toward a surgery with serious and often irreversible consequences without fully understanding what the evidence says about watchful waiting. Any physician who dismisses active surveillance without walking you through what the PROTECT trial actually found is not giving you the complete picture. And you are entitled to the complete picture. Now, the third surgery is one that surprises many people when they hear how much the evidence has shifted in recent years. The third surgery is open heart surgery for aortic valve replacement when a minimally invasive alternative already exists. Aortic stenosis, the narrowing of the heart's main valve, becomes increasingly common after 65. For decades, open chest surgery was the standard approach. Then came TAVR, transcatheter aortic valve replacement. A new valve is delivered through a thin catheter inserted into an artery in the leg. No chest incision, no heart-lung bypass machine, no sternum split open and wired back together. Major randomized trials, including the PARTNER 3 trial, demonstrated that TAVR produced outcomes equivalent to open surgery in intermediate and high-risk patients. And in elderly patients with multiple health conditions, TAVR clearly outperformed open surgery in 30-day survival and speed of recovery. If your cardiologist recommends open valve replacement without mentioning TAVR, ask this question directly and write it down before your appointment. Am I a candidate for the transcatheter approach? And if not, what specifically makes open surgery the better option for my situation? For most patients over 70 with aortic stenosis, open surgery in the current era requires a compelling and specific justification, not a default recommendation based on older habits of practice. Here is something most people sitting in a surgical consultation would never think to ask, and it may be the most important question on this entire list. The fourth surgery is elective repair of an asymptomatic inguinal hernia in older adults. An inguinal hernia is a bulge in the lower abdomen or groin where tissue pushes through a weak point in the abdominal wall. If yours was discovered incidentally on a scan or during a routine physical, and you have no pain, no discomfort, and no limitation in your daily activities, the current research strongly supports watchful waiting over immediate elective repair. A study published in the Annals of Surgery followed elderly patients with asymptomatic hernias for 5 years and found that the vast majority did not progress to emergency complications. Their quality of life was similar to those who had elected repair. Meanwhile, hernia surgery in a 75-year-old with even mild cardiovascular disease or diabetes carries real anesthesia risks, a recovery period of 4 to 6 weeks, and a meaningful chance of chronic nerve pain at the surgical site that can persist long after the incision has healed. Few people know they are entitled to say not yet. If your hernia is not causing you pain or limitation, document it, monitor it with your physician regularly, and unless it becomes painful, rapidly enlarging, or trapped, there is no medical urgency to operate. Watchful waiting is not passive. It is an active, evidence-supported choice. And the fifth surgery is one that affects an enormous number of older adults and where the evidence has shifted significantly in recent years. The fifth surgery is elective colon resection for recurrent uncomplicated diverticulitis. Diverticulitis, inflammation of small pouches in the colon wall, affects roughly 1 in 3 adults over 60. After a second or third episode, many surgeons recommend removing the affected section of colon to prevent future attacks. For decades, this was considered standard practice. But evidence from the DIRECT trial, published in JAMA Internal Medicine, showed that elective colon resection after recurrent uncomplicated episodes did not result in better quality of life compared to conservative management over 5 years of follow-up. For elderly patients with cardiovascular disease or diabetes, colon surgery carries substantial risks including infection, prolonged hospital stays, and complications that can meaningfully diminish independence during recovery. The critical word here is uncomplicated. If your diverticulitis involved an abscess, a perforation, or a fistula, that is an entirely different clinical conversation, and surgery may be completely appropriate. But for episodes that resolve with antibiotics and rest, studies indicate the evidence no longer supports rushing to the operating room as the default next step. Now, here is exactly what I want you to do with this information before you or anyone you love agrees to any elective procedure. Before signing any surgical consent form, prepare 3 specific questions and bring them written on paper to your appointment. The first question is this: what does the published research show specifically for patients my age, with my health conditions, not patients in general? Ask for your situation, not the average case. The second question is this: what is the evidence for non-surgical management, and how completely and how long have we actually tried it? physical therapy, medication, watchful waiting, lifestyle changes. Have those options been genuinely exhausted, or is surgery being recommended as the first serious intervention? The third question is this: can I get a second opinion from a specialist at an academic medical center before I decide? A second opinion is not a rejection of your physician's judgment. It is your right as a patient. It is the medically responsible thing to do, and any physician who discourages it is worth reconsidering. Keep copies of your imaging results and lab reports in a single folder that travels with you to every appointment. Bring a trusted family member or friend to surgical consultations when you can. A second set of ears catches things you might miss when you are anxious or processing difficult information, and do not let anyone rush you. Urgency around elective surgery is almost always a signal worth pausing on. Genuine surgical emergencies are unmistakable. If someone is pushing you toward the operating room faster than you are comfortable moving, it is entirely appropriate to slow down, ask for more time, and get more information before you decide. Many of the people I have worked with told me the same thing after taking more time and seeking a second opinion. They said they felt like they could finally breathe, like the decision was actually theirs to make. That is exactly how it should feel, because it is your decision, and you are entitled to make it with the full picture in front of you. Drop a comment below and tell me which of these 5 surgeries surprised you most, or tell me if you or someone you love has faced one of these decisions. I read every single comment, and your experience may help someone else ask the right questions before it is too late. If this gave you something useful today, please share it with someone you care about who is facing a surgical recommendation right now. One conversation with the right information at the right time can genuinely change what someone decides. Subscribe if you have not already, because next week I am covering the prescription medications that geriatric specialists now flag as particularly risky for adults over 70, including one blood pressure drug that studies indicate is still being prescribed as a first-line treatment in primary care offices across the country. That is a video you will not want to miss. Take good care of yourselves. I will see you next week.